Um, the Office of Health Equity, Diversity, and Inclusion are pleased to have Dr. Dorneshia Thomas and Captain Charles Alphin to discuss an exploration of Dr. King's nonviolence philosophy, wellness and patient care implications. Just a few items to note. We are recording today's session and it will become available. We will probably put the link in an email and have that sent out. If you're not internal, feel free to email our host and we can send that link to you. I'd like to introduce our speakers for this afternoon. I'd like to introduce Dr. Dorneshia L. Thomas. Dr. Thomas works as a psychotherapist in Silver Springs, Maryland. She graduated from Howard University with a PhD in clinical psychology with a minor in neuropsychology. She completed her postdoctoral fellowship here at Albany Medical Center in the Department of Psychiatry, which is how I had the occasion to meet Dr. Thomas. Dr. Thomas was trained in Dr. Martin Luther King Jr.'s nonviolence philosophy and methodology as a high school student while a student at Martin Luther King Jr. High School. She has conducted research in Kingian nonviolence at both the undergraduate and graduate levels. Her dissertation research focused on whether attachment styles are associated with a person's capacity to endorse a Kingian worldview. I'd also like to introduce you to Captain Charles L. Alphin Sr. He received his Bachelor of Science in Law Enforcement and Criminal Corrections from Northeast Missouri State University. Captain Alphin served as a police officer for over 26 years in the St. Louis City Police Department and was trained in the philosophy and methodology of Kingian nonviolence in the late 1970s by Dr. Bernard Lafayette Jr., who served on the executive staff of Martin Luther King Jr. In 1992, at the request of Mrs. Coretta Scott King, Captain Alphin moved to Atlanta, Georgia to work at the Martin Luther King Center for Nonviolent Social Change and served as Director of Education and Training in the King Center. In 1996, he retired from the King Center and joined Lafayette and Associates, where he serves as senior trainer, as well as at the King Center. So please join me in welcoming Captain Alphin and Dr. Thomas today to present.
Wonderful. Thank you, Dr. Antonikowski, for those introductions. And we would also like to thank the Office of Health Equity, Diversity, and Inclusion for inviting us today to have this talk with you. It's quite an honor, and we hope that you will learn a lot through our experience and time together. So we're going to go ahead and get started because we want to make the most of our time here. I see that a lot of people have their video cameras off. If it's at all possible for you to turn your camera on, that would be really helpful because we're going to try to make this an interactive presentation, and we can do that more optimally if folks have their cameras on. But if you can't, we have alternatives. Okay. All right, so we just want to be upfront and honest about any potential conflicts of interest. And as it was stated by Dr. Antonikowski, I do research in the area of psychology and nonviolence. And Captain Alphin is a consultant for the King Center and also Lafayette and Associates. And he's the owner of DDK Civil Rights Tours, and he is paid for those services rendered. And be upfront with you about those things. Now, moving on to our agenda for the day. So we're going to start today by talking through some introductory questions. Then we're going to move to some nonviolence myths and facts. And then we'll talk about some key terms. We'll talk about the 6 principles of Kingian nonviolence. We'll look at some examples, practical examples of nonviolence in medicine. And then we'll take some questions. Then we'll wrestle with this question of can nonviolence really work? Then I'll introduce you to the Kingian neurorelational theory, and then we'll look at some possible health implications. Okay, so here's our first point of interaction. And again, if you can turn your video on, that's great. But what we want you to do is to type in the chat what comes to mind when you hear the term nonviolence. So what comes to mind when you hear the term nonviolence? Either you can type it in the chat or you can just say it. So some folks have said passive, love, peaceful. I believe someone wrote complacent, patience, kind, de-escalation, civil disobedience. Okay, Christ-like. All right. Wonderful. Now, second question. What comes to mind when you hear the name Martin Luther King Jr.? What comes to mind when you hear the name Martin Luther King Jr.? Leader, greatness, civil rights leader, steward, peacemaker, misunderstood, radical love, accountability, wisdom, civil rights activist, brave, visionary. Okay, wonderful. Thank you for that participation. So as we're going through our talk today, we want you to keep these associations in mind. And we want you to see if what we share today affirms or challenges or expands the assumptions that you already have associated with these terms, okay? So keep those things in mind. All right, last question. So the talk today is about the implications of nonviolence, Kingian nonviolence for personal wellness and patient care. Does anybody have any initial thoughts about how Dr. King's philosophy of nonviolence could be associated with those areas? Again, you can unmute and say it, or you can type it in the chat, whichever your preference. Equity, willingness to listen and reason, access to care. Being able to hear what others are communicating. The principles directly apply. Care and compassion. Nonviolence begins with stopping harm, doing no harm is the oath taken by physicians. Much harm has been done historically to Black and brown people in the country under the guise of medicine. Okay, all right, so it sounds like we got a pretty informed group here today. And you all already have some good working ideas about how nonviolence can apply to healthcare. So hopefully we can enhance and expand that through our talk today. All right. So now what we're going to have you to do is we can do this one of two ways. The easiest way to do it is for folks to raise their hand, and those of you who are not showing your faces, you can raise your virtual hand, and that would suffice, okay? If we can see your face, then you can just raise your actual hand, okay? So we're going to take a look at these statements, and these are common either facts or myths related to nonviolence, and we want to know your opinion about whether you think these are facts and myths. Now, I know some of you will want to be really polite to Captain Alphin and myself and may not want to say what you really feel. But I'm going to beg you not to do that, okay? In social justice work, we've got to be able to be honest with each other We've got to be able to tolerate people disagreeing with us. So you won't offend Captain Alphin and myself if you disagree with everything we say today. Okay? What's important is you be honest about your opinions and you share those and we can talk about them together. That's what's most important. Okay? So now, let's look at number 1. So either you're going to raise your actual hand or your virtual hand. If you don't know how to do the virtual hand, then just type your answer in the chat. Okay, and we're going to go through this rather quickly. So 1, is this a myth or a fact? True or false? Nonviolence is only effective when you outnumber the opposing force. If you think that's true, raise your hand. Okay. If you think that's false, raise your hand. Okay. All right, so we had nobody on true. Okay. All right, let's look at the next one here. Dr. King is given the credit for discovering nonviolence. If you think that's true, raise your hand. I see we got 1 raised hand and people typing false in the chat. All right, and if you think that's false, raise your hand or type it in the chat. All right, false. Okay, all righty. Number 3, Dr. King was successful using nonviolence in the 1950s and 60s, but things are different today, and it won't work. If you think that's true, raise your hand. Okay, thank you for your honesty. If you think that's false, raise your hand or type it in the chat. Okay. All righty. Now, number 4, demonstrations, protests, and confrontations against legal authorities describes nonviolence. If you think that's true, raise your hand. Okay. All right, that one looks like we're going to get more of a mixed opinion on this one. All right, if you think that's false, raise your hand. Okay. All right, next one. Nonviolent solutions tend to be more permanent. If you think that's true, raise your hand. Okay. If you think that's false, raise your hand or type in the chat. Okay. All right, next one here. In some circumstances, violence helps produce nonviolent solutions. If you think that's true, raise your hand. Okay. All right, if you think that's false, raise your hand or type in the chat. Right? And last one here, nonviolence is the opposite of violence. If you think that's true, raise your hand. Okay. If you think that's false, raise your hand or type in the chat. Okay. All right. Thank you for your participation in that exercise. Now I'm going to turn it over to my co-presenter here, Captain Charles Alphin, and he is going to talk with us about some of these statements and whether or not they're myths or facts.
Yeah. Thank you, Dr. Thomas, and also the people that are listening. It is my honor to share with you, to dialogue with you, a very important message now, the times that we're in, about nonviolence and Dr. King. I was converted to this philosophy in 1981 by Mrs. Coretta Scott King and Dr. Lafayette. So I come from violence in St. Louis, Missouri, racism, being violated, et cetera. So I had to change my way of thinking about this. I thought nonviolence was praise the Lord, marching and singing. I didn't want any part of that. So let's look at the myths and facts. The only one that is true on this myths and facts is number 5. Number 5. All the rest of those are false as far as Dr. King, the Kingian nonviolence philosophy. And Dr. King was elected when he developed this philosophy. And Dr. King is considered and recognized by the American Philosophical association as a philosopher, in addition to his other contributions as a preacher, educator, and leader of nonviolent campaigns. So when he developed this philosophy, it's very narrow. There's volumes of books written on nonviolence, but we're going to talk about the Kenyan nonviolence. And he pulled from Gandhi. And then I was in India studying in 1992 and 93. We found out and understood that he pulled a lot from Gandhi, but Gandhi's philosophy is different from Kenyan philosophy, but there was a lot of things pulled. So I'll go with the two things that we're looking at now. Number 4, demonstrations. Demonstrations, protests, and confrontations against legal authorities describes nonviolence. That word describes makes it false, because nonviolence is not simply a method of protest, but a system of thought, philosophy, art, methods, and strategies whose purpose is bringing about complete change. So Dr. King was talking about complete change, reconciliation. There's a little difference between reconciliation and resolution. And number 5 says nonviolence tends to be more permanent. Well, first of all, it's more permanent because the characteristic of change makes it more permanent. Dr. King said that if you have a goal in the medical division for people to do right and treat people right and learn, then your ways to achieve that has to be consistent with what you say you want. You can't use destructive means to create constructive goals. So it's the method that you go by to create this more permanent, because it's participatory and is concerning and understanding the needs of human beings, regardless of their stature in life. Gandhi said that in my philosophy of life, my means and my ends are convertible terms. You can see my ends in my means. So in supervising with people as a commander of homicide and narcotics and child abuse, and also district, I had to understand the officers' needs and make sure that I wasn't violating their needs and trying to achieve a goal through means that was not consistent with my goal. So therefore, this is a little taste of Dr. King's understanding and how he developed this after he read all types of philosophers, Thoreau and Walter Rauschenbusch and Reinhold Niebuhr and Hegel, and developed this into a philosophy of 6 principles. But that's a little conceptual understanding of what we're talking about. This helps level the playing field, so when we get into the principles, you'll have a much more understanding of what we're talking about. Okay, the next one. Broadly, we define violence. Most people, when we're talking and ask them, are they nonviolent? They say, yes, I'm nonviolent, but they look at the physical nonviolence, but there's much more, as Dr. King agreed, defined nonviolent, and Mrs. King, and nonviolence was much more than just physical. In fact, the emotional and verbal is much more devastating sometimes than the physical. In my soft study of homicide in the city of St. Louis, I found that most people will kill you for what you say, that your words are the most dangerous weapon you have in your body, your tongue, because your tongue can cause people to hate you and want to kill you. And it's not only just in the community, it's in the church and in the business and in the corporate world, and also in the medical world. Your verbal words and your emotional, your violation of the person's spirit. Most people want to feel good about themselves, and everybody wants to need to feel good about themselves. And Dr. King very early on understood personalism, and Dr. Thomas will talk about that personalism, that inclusiveness, that diversity, that respect for humanity. And that was what Dr. King learned in Boston when he really understood the spark of divinity in all of us. The next one. Now, this word was awfully complicated to me, because in law enforcement, we had nonviolent criminals. Well, there's no such thing as a nonviolent criminal, because every time you do violence, you violate somebody. When you violate a person's humanity or their potential to be the best they are, that's a form of violence. So therefore, nonviolence is nonviolence. You can't use nonviolence to create violence, because you violated what you're saying you want. So nonviolent solution does not result in nonviolent. More nonviolence does not result in a nonviolent solution. A dominant force may quiet a lesser force, but it cannot create nonviolence. So therefore, this nonviolence we're talking about is not spelled with a hyphen. It's a philosophy, a method of art, looking for complete change. The other word, non-hyphen violence, means that in the English language, when you hyphenate a word, it means lack of the essential ingredient in the specified word. So non-hyphen violence means lack of violence, lack of alcohol, lack of organization. But non-violence without the hyphen is the cure to violence. It's the antidote. It's not the opposite. The opposite of violence is peace. And Dr. King and Gandhi took peace and divided it into two parts, negative peace and positive peace. And Dr. King said, as long as you have the triple evils in your society and your environment and your workforce, you have a negative peace. The triple evils are racism, poverty, and militarism. And so therefore, those triple evils violate people. And that's why he said that in the workforce, when you don't have, when you have deficits of health care, when you don't have adequate health care, that's a form of violence. And so he said true peace is not just the absence of tension, but the presence of violence. A lot of times in our workforce, in our homes, with our relationship, we have a negative peace. But true peace is not the absence of violence, it's the presence of justice. And I've used this philosophy with my wife. I'll be married 60 years next month, same woman. And without this, I would have probably been divorced because I had to understand how violent I was with my tongue, my attitudes, my response to my wife and my children. I'll stop there and now get into the 6 principles. After reading, Dr. King went to school and studied for 18 years, and then he came out and went to Montgomery, and he had a academic, intellectual understanding of the philosophy, but he didn't have any human experience, and he was able to apply his philosophy to the Montgomery bus boycott, where he did not ask to be a leader, and he did not usher in nonviolence. He just led by leading what he thought and what he understood intellectually. And after the Montgomery bus boycott, he developed these 6 principles. Now, Gandhi had a lot of principles, but these were the 6 that Dr. King developed to say, if you want to deal with this from a human perspective, dealing with relationships with people, respecting humanity, these are your guidelines. In the workforce, how do you get people to work for you, with you and for you and buy into the concept? These are the 6 principles. Now, number 1, nonviolence is the way of life for courageous people. It takes courage to do this. I saw one of the chats say that you have to step out your comfort zone. You can't be in your comfort zone in this. It takes courage. The beloved community is the goal. The beloved community is where everybody is lifted to their fullest potential, and there's no violation of the human personality in that beloved community. And that's what Dr. King was looking for. That was his ultimate goal. And then you attack forces of evil, not person doing evil. That means hard on the problem, soft on the people. And that's the way Harvard teaches it. But you focus on the behavior of, not the behavior of people, but what's caused the behavior, what's causing that person to act like that. Once you change that, you'll change the person. Accept suffering without retaliation for the sake of the cause. I had a problem with this because I didn't want suffering. So I had to go back to the root word of suffering, Hebrew and the Greek. Suffering means I'll allow you, I permit you. So you can change that word suffering to sacrifice. And the students say, we teach the students, there's nothing in life achieved without a sacrifice. So that sacrifice means you have to have a cause. If you don't have a cause, it can be victimization. So you're sacrificing for what you believe in, and that cause is what makes you accept the suffering to achieve the cause. Number 5, avoid internal violence of the spirit. And that's very hard, very, very hard, because the words that we use, how we violate people's spirit, that can really cause a lot of violence emotionally and psychologically, et cetera. So Dr. King said, not only do I refuse to hate you, I refuse to kill you, I refuse to hate you, because hate can be emotional. I had to understand that because I was not ready to do that at that point. And then the universal on the side of justice. He talks very in depth in his writings that there's a cosmic companion, and you call it what you want. He called it God. He called it divine order, but you call it what you want. But in the universe, there's a cosmic companion, and the root word of cosmic is cosmo. It means there's a balance up there that creates justice. So, and the justice we're talking about is not the criminal justice system. It's the universe, not the criminal justice system. So therefore, That's the vision that he had. That's what he kept in mind when he looked at solving problems, not only in the United States, but around the world. This university, this is a universal application, not only in the United States. It's about the whole world, and the world house he talked about, and the beloved community. So I'll stop there, but those are the 6 principles that you have to adhere to when you're managing people, when you're relation with your parents, relation with your spouses, your partner, just a way of life. This is what Dr. King is talking about. He's talking about a way of life.
Okay, thank you, Captain Alphin. Now, it may feel like we're moving through this material rather quickly, and that's true, because our goal here today is to give you a brief and wide exposure to nonviolence. With time constraints, we can't get too much into detail about these things, but we want to put it out there and get you thinking and encourage you to go study and learn more about it. So now we're going to transition to a little bit more practical applications as far as medicine is concerned, or healthcare broadly. So in preparing for our talk, we consulted with one of our colleagues, Dr. Marbin. And in 2019, Dr. Marbin took a group of her pediatric residents on a civil rights tour with Captain Alphin, and they went to the American South. They went to Georgia and Alabama. And the goal of this tour was to help the students to think about the historical legacy of structural racism and to have a real-time interaction with people and in the places that were critical to anti-Black racism and with people who have been fighting anti-Black racism in American history for some time. And so they took the students on this tour. They wrote up a paper. The title of that paper is The Power of Place, Travel to Explore Structural Racism and Health Disparities. And we talked with Dr. Marbin, and Dr. Marbin shared with us the experience of one of her residents when they came back from the tour. So in the paper, they assessed the impact by having them to do surveys and follow-up conversations. And so she shared with us an impact statement from one of her residents. And I'm going to share that in a little while, but I'm going to flip it back to Captain Alphin here because he did the trip. And I think it could be helpful for y'all to hear just a little bit about what that trip was like. And then we'll move forward to looking at how the resident applied that experience to her experiences in the hospital.
Thanks, Dr. Thomas. Yes, Dr. Marvin was at the University of Rhode Island, and I have a annual tour dealing with professors and people of political science out of the New England area. And she took the trip by herself first, and then she went back and decided that it would be helpful for the medical students and also medical doctors to come. And we talked and we looked at a curriculum, and they organized, I think, about 25 people that came from the University of California, San Francisco, University of California, San Francisco. And we started off at the airport and on a bus, and we had video during the bus. And it was really a classroom on wheels because during the visit of different historical sites, we started in Atlanta and went into Tuskegee, and then Montgomery, Selma, Birmingham, and then back to Atlanta, the Mecca. And during this time, we spent 2 days in the hotels, and evening we had sessions. They had facilitators to connect this philosophy, connect these principles to the medical field, and asked me a lot of questions about how would they apply my experience, not only in the United States, but globally. And we really facilitated a learning experience, and that's what the whole trip was about. She's been on the trip 3 times with Dr. Marvin, and that's what we did, and that's what I do to expose people. We went to the Slave Museum, Brian Stevenson, from slavery to mass incarceration, and that was a tremendous emotional experience because people had not seen that, didn't know a lot about that information or history, and it precipitated a whole dynamic conversation about the respect of humanity and also the respect of human dignity.
Okay. Now, Dr. Marbin makes the case in her paper that if medical education is going to really have a role in dealing with structural racism, then new approaches have to be taken. And this educational experience that she provided to her residents is one of those approaches that the literature makes a case for can be very powerful in making that change. So before I read this, so now Dr. Marvin is the director of a joint medical program between the University of California, Berkeley and the University of California, San Francisco. Up at the University of Rhode Island, there is a Kingian Nonviolence Training Center. And one of our colleagues, Dr. Charles Collier, was critical with Dr. Bernard Lafayette in getting that up and running. And that is likely where Dr. Marvin and Dr. Collier crossed paths, and she became aware of these things and then went on to get involved with Mr. Alphin and apply it in her professional context. Okay, so this is a statement that she shared with us from one of her residents who went on this trip. The resident says, I remember going into my first shift after the trip. It was Easter Sunday and I was at the General Hospital. Immediately, I was confronted with the reminder that violence is inflicted in our healthcare system every day. There was a postpartum woman with armed policemen outside of her door, shackled to the bed next to her newborn in the bassinet. Prior to going on this trip, I would usually do everything in my power to make it clear I was an ally to my patient and my patient only. I have previously found myself being defensive when law enforcement is present in the clinical setting, as if I need to somehow fight to demonstrate my patient or their parents' innocence, their personhood. However, after learning about the principles of nonviolence, I realized that this stance was antagonistic. I instead made an effort to work with the officers, welcoming them and asking them how the patient and her baby were doing every time I entered the room. In the past, I would have ignored them. I mean, maybe a curt smile, but I realized the need to create a shared sense of responsibility, to reinforce the fact that we are all on the same team and that we have to be on the same team to provide the best care for this mom and her baby. In allying around this work, the perceived aggressor becomes a comrade, recognizing the common humanity between who was on the other side of that door and who was standing in front of it. Okay, so that captures the impact that the trip had on one of Dr. Marvin's residents. Okay. All right. So I'm going to stop here and see if there's any questions that anyone has at this point for us. If not, we'll move along. Okay, hearing nothing, we'll keep going. All right, so now we're going to wrestle a bit more with this question of, can nonviolence really work? Because that's a major question that's been wrestled with for many years now. Now, to sum up what Captain Alphin went through. So Dr. King had a lot to say about the topic of societal violence, and he defined it broadly, okay? And societal violence was a critical threat to his concept of the beloved community, okay? And the beloved community is essentially a diverse and inclusive community where all the barriers that separate us are removed. That's how he would define a beloved community, okay? And he was convinced that the only way we get there is if we pursue justice through nonviolent means, and if we learn to function nonviolently in every area of life. Call that nonviolent daily interactions, okay? Because after we have pursued our justice cause, society has to be able to come back and live together in a reconciled manner. And nonviolence gives us the best path to achieving it. Okay? So King was committed to nonviolence in the pursuit of justice. Now, I saw a hand go up. Does that mean we have a question? Oh, that was accidental. Okay. All right. So, a critical aspect of Dr. King's philosophy of nonviolence was what's called personalistic philosophy. Okay? And it said that King took from personalism meliorism, inclusiveness, cooperation, unity, and the value of human personality. And King explicitly stated that it was personalism that gave him a metaphysical basis for the dignity and worth of all human personality, including those people who we might see as our opponents, or if we go as far as seeing them as enemies. Value of all human personality, okay? And when we think about the definition we gave earlier of violence that King used broadly as emotional, verbal, physical harm, and we think about how modern psychology understands violence, our argument is that there is overlap in those understandings of violence. And that overlap allows us to get to what we're calling the Kingian neurorelational theory. Now, before I tell you explicitly what the Kingian neurorelational theory is, I'm going to talk to you about a theory in psychology that we have called attachment theory, okay? And then once I explain attachment theory, then we'll get back to the Kingian neurorelational theory. All right, so attachment theory was developed by a psychiatrist named John Bowlby. And Bowlby argued that humans form these attachment bonds with their caregiver, and they start as early as possible in human development, okay? And these attachment bonds are intended to aid our survival and reproduction because a human infant can't survive on its own. The human infant needs somebody to take care of it. And because of that, this attachment system is a biological necessity across our entire lives, okay? And there are three basic elements to the attachment system, or three roles that an attachment figure serves for us. That's proximity seeking, a secure base, and a safe haven. And I can't give you any details on that today because we don't have time for it. But it's not critical to understanding the major points. So stick with me. Now, the end goal of the attachment system is to establish within us what we call a felt sense of security. That means a sense of security and safety, both psychologically and physically, that the person experiences. And when we have that major attachment need met, it allows us to have the capacity to explore. That's the capacity to explore various aspects of the world around us, including the internal world of other people and ourselves, okay? So just for some further description about this idea of felt security. A subjective state that hinges not on the behavior of the caregiver alone, but on the child's internal experience as well, including his or her own mood, physical condition, imaginings, and so on, okay? So I hope that helps you to understand this felt sense of security. All right, now in my research, I'm primarily concerned with attachment in adulthood. There's a whole literature on attachment in childhood. There's lots of overlap and consistency. There are some areas where there are things thought about a bit differently in adulthood versus childhood. Again, the main point is the same. All right, so for a little more details on attachment styles. So we have these attachment bonds with our caregivers, and they're thought of as either healthy or unhealthy. And these attachment bonds are referred to as attachment styles. In the literature, the language of healthy and unhealthy is not used. We use the language of secure and insecure attachment. And researchers tend to think about attachment styles in two different ways, okay? In a continuum fashion, where we look at the degree of attachment avoidance and attachment anxiety that someone has. The other way is we have categories that when you look in human society, there are common patterns of behavior that are manifested. And that's been taken and put into categories of attachment styles. So one category of insecure attachment is preoccupied, another is fearful avoidant, another is dismissive avoidant, and there's also a measure that gives us a disorganized or unresolved attachment style. And then those are the insecure ones. We also have the secure attachment style, which is thought to be the healthiest pattern. Okay? Now, these attachment styles have lifelong implications and are difficult to change. And the impact of attachment styles is not limited to parent-child relationships. So attachment has implications for work relationships, romantic relationships, spiritual relationships. The literature shows us that there's a relationship between our attachment styles, how we handle conflict, how we perceive emotions, how we experience pain, our tendencies towards violence. So attachment is related to a whole lot of stuff, is the moral of the story, okay? Now, our argument is that when we look at Kingian philosophy and personalism, when we look at attachment theory and psychology, when we look at modern neuroscience, there is some significant overlap about how these perspectives understand human development, okay? And when we can appreciate that consistency, it allows us to get to the Kingian neurorelational theory. So my hope is that these quotes here will help you to appreciate that consistency, okay? Now, quote 1 is from Kingian personalism. There is a logical relationship between the personal and the social, and that people naturally express themselves in terms of community and naturally need fellowship with others. This interaction affects each of us. We develop and grow as persons interacting with others in social relationships. That's Kingian personalism. The next one are attachment and relational perspectives in psychology. Psychopathology develops out of the inherent difficulties people have in forming the relationships that they need for their psychic growth. The last central claim here is from social neuroscience. Individual neurons or single human brains do not exist in nature. Without mutually stimulating interactions, people and neurons wither and die. From birth to death, each of us needs others who seek us out, show interest in discovering who we are, and help us feel safe. We create each other through relationships, okay? Now, I hope that highlights and emphasizes the compatibility between these different areas of study, okay? Now, here goes the Kingian neurorelational theory. So it's a newly proposed psychological theory of nonviolence. As we've talked about, is based on Dr. King's understanding of nonviolence. It incorporates attachment theory, neuroscience, and Bronfenbrenner's ecological systems theory, and is primarily focused on the developmental and clinical implications of nonviolence theory. Now, here's the theory in a nutshell, okay? So KNRT contends, since King's understanding of human development is on point with modern science, then perhaps King's strategy that we need to institutionalize and internationalize nonviolence to a high degree all over society, perhaps that strategy is scientifically viable and scientifically sensible, because nonviolent engagement should help to produce that felt sense of security. And a felt sense of security should increase the likelihood that the neuronal pathways in the brain are structured and organized in a manner that will help to increase people's capacities and inclinations for pro-relational activity as opposed to anti-relational postures. If people feel more connected, ideally more securely attached and valued by and within society, from the microsystem, the immediate environment, to the macro system, societal values and beliefs, they will generally be less inclined to be violent, because there's no need to be violent if one feels psychologically, physically safe. So the motivation for violence at a psychological level comes way down, okay? That's the fundamental argument of KNRT, the Kingian neurorelational theory. And KNRT offers us a way of understanding King's ideas to aid research and develop strategies for reducing many forms of societal violence, with eventual outcomes of improving mental and physical health via stress reduction and subsequent creation of a more socially just world. Okay? I know I'm moving fast here. I hope you're still with me. I'm going to stop for questions in a moment because we're racing against the clock here. Now, a critical component of KNRT is this idea that we call violence sensitivity, or sensitivity to violence, or stated differently, violence awareness. And in the KNRT model, it's important that we have insight that the highest level of understanding is that what a particular person experiences as violent is to some degree relative to their own personal, relational, and attachment history. So to say that differently, there are some behaviors that if I polled the group, everybody would say, yeah, Dorneshia, duh, that's violent. But there are other behaviors where we may not understand why on earth the person seems to be reacting in a way that suggests they're experiencing what's happening as violent, right? Because they're reacting that way because of something in their own attachment and relational history. And we may not be aware of, but it's still to them violent, okay? Now that level of attunement is necessary if we are going to get to the fullest idea of the beloved community, okay? Last concept I'll give you. This idea of what we call developmental privilege is central to KNRT. And this is what it states: that having developmental privilege is having inherent advantages in terms of one's psychological health, physical health, and daily functioning as a result of benefiting from more regular, consistent, healthier interpersonal interactions and or being in healthier environmental spaces during the course of one's life in a society characterized by inequality and injustice. This is especially important to consider in the context of critical developmental periods with one's attachment figures. Developmental privilege also extends to being the offspring of persons and or having ancestors that have had similar experiences. DP would also pertain to persons whose brains do not have the added stress of coping with a mental disorder, trauma, or any form or degree of injury to the brain. All right, I've given you quite a bit. We're getting to the end here. This is a paper that I will have coming out later this year in the Journal of Black Psychology that explains these things in more detail. If you want to know when it comes out, I'll give you my contact information at the end. You can email me, I'll let you know. Here we go. So this is how, or some ways to think about how these concepts we've talked about apply to the healthcare experience. Okay, I'm going to give you a chance to look at this slide and then we'll take questions. This list is not exhaustive. Neither are they mutually exclusive, but it just gives you an idea. Okay, so do folks have questions at this point in time? I see a hand raised.
Yes, I think you're referring to me. Thank you for this. This was really informative and important, and it makes me think a lot about, there's a lot of discussion about trauma-focused healthcare, right? And there's a lot of discussion about how providers can be trauma-informed. But it sounds as if this version of nonviolence really speaks to a different take on that. So when I think about trauma-informed healthcare, it doesn't necessarily include the provider as part of that system. And this approach speaks more to how the provider is a part of, or can contribute to, or can help heal violence. Can you talk a little bit more about, or talk a little bit more about how this is similar to or different from this idea about trauma-informed healthcare?
I would say it's similar to, but probably goes a bit further than as you highlighted, because it points to the role of everybody, including the system, and what we can all do to make that patient have a better experience just in the hospital context, but more importantly, to have the most optimal path to healing, right? Because if all this violence as we understand it is inflicted upon the patient, that's going to make things even harder for giving the patient the care that they're supposed to be being given. I'll tell you a story that I think is relevant to this. I'm going to refer to the patient as patient Red Fox, okay? Now, patient Red Fox lived in a residential center for a long time. And patient Red Fox had a lot of health issues and mental health issues, including a diagnosis of borderline personality disorder, and had issues with hoarding. Okay? So, patient Red Fox was cared for by an interdisciplinary treatment team. Some members of the team got together and decided, okay, when patient Red Fox leaves the center to go for a medical procedure, we are going to take all of the stuff, the hoarding items, out of the patient's room. Some members of the treatment team decided to do that. They didn't tell other members of the treatment team, including the person's therapist. And can you imagine what happened when patient Red Fox came back and this had been done? Patient Red Fox was devastated, right? For those of you who don't know, just having a diagnosis of borderline personality disorder means patient Red Fox really struggles with interpersonal relating. And then providers who patient Red Fox is supposed to trust with taking care of her or him do something like this. That's a deep act of violence, an act of betrayal, and makes the clinical picture even more complicated, right? So I think that example speaks to this whole idea of trauma-informed, because that wasn't trauma-informed at all. And in that case, they had the option to be trauma-informed, but if you can appreciate the dynamics going on there, they didn't utilize the options that they had to make a trauma decision. So I think that touches on it a little bit there. Does that answer your question, Dr. Antonikowski, a little bit there?
Yep, it does. I just got another question. Someone's asking, can you speak a little bit more on how this approach can be used around wellness?
Sure. So I think Captain Alphin touched on that a little bit when he was just talking about his own personal experience of being a captain in a police department, and he had struggles in his marriage and with his kids and relating to them in a nonviolent way. But if we think about students, right? Medical students, residents are under a lot of pressure, right? And how we relate to ourselves when we don't do well on a test, or when we don't get the score on the test that we want, we can't go on to be the type of doctor that we want to be or whatever, right? If my orientation is to relate to myself, let me go to this last slide here, which captures some of that. If my orientation is to relate to myself in a nonviolent way, then I'm going to be able to be more compassionate with myself when these things don't go the way I want them to go, right? Which is really important if I've been training myself my whole life to be really critical towards myself. And that's not going to help me, right? Or when we think about, just from an educational perspective, thinking about what are the demands that we're putting on our employees, our students, or whatever, and are these demands realistic in light of what we know about human development? Or are they not, right? And where are we going to place our priority? On money, material things, whatever, or on the well-being of our workforce, right? If our workforce feels safe in our care, then they're going to function more optimally. You'll make more money anyway. But if they don't feel that way, then you're going to have a lot of problems, right? So those are some of the ways individually, systematically, that this applies to personal wellness, okay? How we relate to our own selves internally, how systems are relating to individuals. When we think about patients and meeting them where they are and understanding the different factors that have contributed to the situation that is before us, that can help to regulate some of our own biases and things like that, and be more understanding and collaborative when the patient, right? Or when a patient challenges a decision that we make. Can we tolerate that, right? If we are oriented towards nonviolence, then we should be able to tolerate that dialogue a bit better than if we're not.
Yeah, and Dr. Thomas, certainly, just to add a few, this philosophy Dr. King developed is for you. It's the 6 principles for your behavior. Well, Dr. King would always ask himself, what percentage of the problem do I bear? And he'd asked himself that before he started working. Now, we have the 6 steps we haven't gone into. That's the methodology. Then that means that as I begin to apply this philosophy, the solution, et cetera, I have to look at my behavior. Because Dr. King said, sometimes society breaks your leg and then persecutes you because you're crippled. So therefore, this is the principles of your behavior. Now, if you don't have these principles, the 6 steps are nothing but another problem-solving process. It has no foundation.
I see we have another hand raised. We'll try to get your question in here. I don't see any names, so I can't say a name, but I see a hand raised from a young lady. If you have your hand raised, your virtual hand raised, and you want to ask a question, do it now. Okay, well, maybe that's an accidental hand raise. All right. Yeah, so I think on this personal wellness question,
Yes.
Societal wellness is tied to personal wellness, right? So the more things are going well in our homes, then the more we have the capacity to function better everywhere else. So it's not mutually exclusive, it's both and, right? So nonviolence not only gives us tools for functioning with our family, but then when we come to work and everywhere else that we go. Nonviolence works in our minds, in our brains, our bodies, as well as our entire community.
Yes, and it has to be practiced, and it's a way of life. It's not something you apply when there's a problem or conflict. It's the way of life, and it becomes secondary. So therefore, once you practice it, like Gandhi said, it has to be practiced. And the best place to practice are people that you say you love. That's when I first started. I went home and looked at myself and practiced it with my home, the people. Sometimes we're more violent to the people we say we love. The way that we talk to them with our tongue, the way we disrespect, not listening to them. So that all that has to do with Dr. King's whole philosophy. I see a hand.
I see a few hands, and I also see that we're at 1 o'clock. So we're willing to stay a little longer if that's possible, to take these additional questions that people have. But if people have to go, of course, we understand, and we thank you for joining us.
Yeah, so we can stay on just a little bit longer, but for those who have to pop off, on behalf of the Office of Health Equity, Diversity and Inclusion, and on behalf of all of us, I would very much like to thank you both for this influential, practical, timely lecture. Thank you all on the call for your attention and participation. We're certainly looking forward to future conversation on this. And if folks can stick around feel free. Otherwise, enjoy the rest of your day.
Yes, indeed. And thank you for all of those that I know that joined us. I really appreciate it. It's such a pleasure to see your friendly and familiar faces. Thank you.
I think there's a question. Let's see. Ishbel, I see your hand is up. Did you want to speak on the question?
Hello?
Okay, I see Francis, I believe, and Joseph have their hands up. And I heard someone say hello.
Yes, this is Joseph.
Okay.
In
Go ahead.
healthcare, can you hear me?
Yes, go ahead.
In healthcare, there is this dichotomy between what is clinical and what is legal. Imagine an intubated, unresponsive inmate in shackles. From a clinical perspective, the person is unresponsive. But then legally, the person is in chains. I'm wondering how we can promote nonviolence in a healthcare setting where there is this division between what is clinical and what is legal.
Mm-hmm.
Oh, wow, that's an excellent question. And I think that we have to, first of all, look at what's good for the human being, morally, what's morally right, first thing. And once we decide what's morally right, then we can make a decision on how we treat that person. Number one, nonviolence is basically common sense. If somebody is violent and is going to hurt you, you certainly don't want to violate them by restrictions, et cetera. But there has to be other ways that we can do that because of, number one, we want to make sure it's safe. But I think that when I, as a police officer, I always dealt with what is morally right, because my profession is police officer, but I'm a human being. And so we had to have a conversation with the medical doctors and look at each one of those and come up together with some solution that would protect your ability to give patient care, and then also to be safe in that environment. So I wouldn't want to put a blanket answer to it other than that when the two of us come together with the person's health and person's dignity, you know, in mind as a goal, we could come up with some solutions.
Yeah. To add to what Captain Alphin said, I think in these kinds of cases, it starts with having conversations like this one about how our health system, our clinic, our whatever, thinks about violence, right? And what type of violence might we be inflicting upon this person either way? What type of violence might we be inflicting upon other people, depending on what we do? And to stop and reflect on those kinds of things. And once we do that, then I think that can help us to decide about, okay, what's clinical, what's legal, how can we honor whatever this person may want. If they're not responsive, then what are the systems in place to honor their personhood and what they want for themselves? I'm guessing, Joseph, your point is that there's no point to have the person in chains if the person is non-responsive. And so that kind of plays back to the other resident example impact statement that we gave of this interaction between the law and what's clinical and all of that. And those two parties have to come together and be willing and open to come together to talk about, okay, in this healthcare space, we have this context of the person can't do anybody any harm. Why do we still have them in chains? Doctors can use their voices to say, I'm not okay with that, right? Because I don't think that this person can do me any harm, and it's dehumanizing to them, perhaps if that's your perspective, to do this. It's excessive, right? So how can we find the happy medium between the law and our clinical practice? It's about being able to dialogue and disagree about these things. I hope that helps to answer that question, or at least shed some
Yes,
light.
I appreciate the dialogue piece. I think that there needs to be a dialogue, a conversation around this subject. Thank you very much.
Now, just in closing, there are some police officers that feel the same way. I know when I was working with doctors, et cetera, and we had our requirement, the policy was to handcuff, shackle to the bed. So you'll have some support with people that are law enforcement that don't believe in that policy that the police department has, with penalty if that prisoner escapes, that officer gets suspended. So these types of dialogue can help us solve it.
Right. Yeah, I think, again, going back to the impact statement, is we don't want to jump to conclusions about what the people in the room may or may not think about that situation. Because as Captain Alphin just said, they may not agree with this either. So then we have to, as a society, think about, okay, who do we have in charge that are making these rules that it seems a lot of us don't really agree with? And then how can we either remove those people from office or start to talk with them and have meaningful conversations so that we can begin to reconstruct a society that's helpful for us all. Okay, other questions?
I think there's one other question in the chat, if you have a moment, that asks, do you believe that organizational hierarchy contributes to this type of violence? I'm not sure exactly what type, but that's the question in the chat.
Okay, the short answer is that yes, how organizations are structured can contribute to violence, but they don't explicitly have to, right? If the people at the top of the organization are non-violently oriented, then they can structure the organization in a way that does not add to these types of violences or any type of violence that may be going on within the organizational system. Okay, so I would say yes, it can happen. It doesn't inherently have to happen. And then, Captain Alphin, is there anything you want to add?
Yes, in our strategy, we look at leadership at the top. We go into police departments, and at the Center for Disease Control, we had a problem. They came to us about diversity with the middle level people. And we went to the top. And once the top buys into philosophy, organizing the top, then it flows down. But it has to be policy from the top, the leadership. Otherwise, people will sabotage it or not do it. So therefore, the way we implement institutionalizing certainly has a way to begin to get people to say that this is the way we work, and this is our philosophy of nonviolence. And then you practice it. You practice it once a year in in-service training, et cetera, et cetera. So yes, sometimes the organizational causes the problem, the organizational structure. Yes.
Great, thank you very much. Thank you, everyone. This was wonderful. I hope all of you have a really wonderful day, and thank you again, Dr. Thomas and Captain Alphin.
Thank you.
Well, thank you. It's my pleasure. Thank you. Have a safe day. Bye-bye.